Good morning, good afternoon, good evening, friends, depending upon from which part of the world are you joining us. And what a fantastic day is this today that I'm Dr. Vijay Agarwal, the president of CAHO, and I have the opportunity to welcome you all by saying a happy new year of 2023, and is also the International Mind Body Wellness Day today. And so a fantastic day to start this series of the CAHO-ISQua programs for this year. And again, I could not have found a better person than my brother, our mentor, our father of quality in India, Dr. Girdhar Gyani, who is also is a main person now at the back of the AHPI, the Association of Healthcare Providers of India, also the founder patron of CAHO, and has been responsible for bringing, I would say, the NABH whole ecosystem in the country was only by his efforts. I'm not going to speak too much about him, otherwise we will not be left with the time for him to introduce another stalwart, Professor Eugene. So I am just handing it over to Dr. Girdhar Gyani to take the proceedings of this webinar forward. Thank you, sir.
Thank you very much, Dr. Vijay Agarwal. And I extend warm welcome to all members of CAHO for this important session today. In fact, not only members of the CAHO in the formal sense, there are a large number of what we call non-members in that sense, who are, of course, part of the extended family of the CAHO. And I must tell my two learned professors who are joining us today that CAHO, I'm sure you know about CAHO now, that CAHO represents the organization Pan-India, which has taken the sole responsibility on their shoulders to promote quality and patient safety in our country. So I think this is a big task. Looking at the size of our country, the kind of work which CAHO has been doing, it is fantastic. And I am proud that I am part of it. So now let us today talk about the patient-reported outcome measures. Now this topic of late has been recognized as single most initiative which can really take the healthcare to next level. And I'm very happy that CAHO has taken this initiative. And I'm sure the way I discussed with Dr. Vijay Agarwal, this will be the important project now for CAHO to implement it on the ground in some of our hospitals as a pilot. And later on, I'm sure this will become movement the way NABH has become movement in our country. So I think briefly 2 lines about the patient-related reported outcome measures. These are, of course, important to in understanding whether the healthcare services and procedures make any difference to the patient healthcare status and quality of the life. PROM, as we call them, provide insight on the effectiveness of care from the patient perspective. That is a key point now. The PROM, therefore, act as measurement tools, and which is the topic today, that the patient use to provide information on aspects of their health status that are relevant to the quality of their life, including physical, mental, and social health. Only one little caution to some of the participants today, that at times we think that PROM is another name for the patient feedback, which generally we use in our hospital. This is not so. Patient feedback is very simple qualitative tools, while the PROMs are quantitative, very procedural, system-based measures, which actually really, as I mentioned this one, that they will take our healthcare services to the next level. And I think to speak on this important topic, I am very happy that Professor Nelson has joined us as the key speaker today for the session. Professor Nelson is Professor of Community and Family Medicine at the Giesel School of Medicine at Dartmouth, the Dartmouth Institute of Health Policy and Clinical Practices. Professor Nelson is a national leader in healthcare improvement and the development and application of measures of quality, system performance, health outcomes, value, and patient perception. I am not going to read the big bio, but briefly, one more aspect I like to mention about him, that in the early 1990s, Professor Nelson and his colleagues began developing clinical microsystem thinking. His work on developing the clinical value compass and whole system measures to assess healthcare system performance has made him well-recognized quality and value measurement expert. He is recipient of the Joint Commission's Codman Award, Ernest Codman Award, for his work on outcome measurement in healthcare. He has authored over 150 publications and is an author of 2 recent books, that is Quality by Design, a clinical microsystem approach, and Value by Design, that is developing clinical microsystems to achieve organizational excellence. He received MPH, that Master in Public Health, from Yale University and the Doctor of Science from the Harvard University. So I welcome Professor Nelson, and along with him, Ms. Kennedy will be joining him, who is a research project manager in the US at the same institute where Professor Nelson is working. And she's also practicing supporting an inflammatory bowel disease quality improvement collaborative called IBD Chorus. She's also part-time PhD scholar at John Pomping Academy in Sweden, exploring data-driven improvement within co-production learning health system and how the vital processes within the learning health system can be driven by the patient they serve. So very relevant area which she is working, relevant for the topic of the day. So I welcome both of you, and over to Professor Nelson.
Thank you for that wonderful introduction, and delighted to hear of your plans to begin using PROMs more extensively in your country. The focus today is on PROMs as a quality improvement tool. And the flow of the session will, first I'll give an overview of PROMs to set us on common ground, and then a series of classic case studies from 1998 to today, and a brief set of comments on how to get started, and then we'll move to questions and discussions. Why PROMs? Our hypothesis is that using PROMs provides the best leverage to improve care experience, health outcomes, healthcare value in science, in ways that matter to patients. PROMs come in 3 different flavors: outcomes, as has been noted, patient reports on their health status and how that changes over time. Second, experience, so-called PROMs, patient-reported experience measures, about the goodness of the care through the eyes of the patient. And finally, personal benefit. How much was I helped by the care that I received, perceived health benefit? I'll be speaking a lot about service value. And what does that term mean? A technical answer is the quality of service in relation to cost to purchase the service. A simple answer is what you get for what you spend. And in healthcare, the goodness of the service experience and the outcomes in relationship to what it costs to receive the service. This is a picture that you'll see several times as we have our discussion, and it focuses on healthcare value. We start out with a person or a population on the left with an initial health status. They go through our healthcare delivery system. They help in the provision of care. And then we can look at 1 day, 1 week, 1 month, 1 year, 10 years later to see how that person is doing. And we say that value is a function of clinical and functional outcomes and experiences and costs. So we can start to overlay PROMs and PREMs on this flow of a person working with our healthcare system. And the point here is that PROMs are happening and PREMs are happening in the flow of care as the patient's journey unfolds. The challenge then is to measure them and to use them. So step back just a bit and to look at a patient's journey, follow the footsteps of a patient as they travel through the healthcare system. From their perspective, this is Amy. Amy, a few years back, had a diagnosis of breast cancer. She was a 38-year-old teacher in an elementary school in Woodstock, Vermont. We have permission to use this case. I had a research assistant who was with Amy every time she visited our cancer center for a 6-month period of time. And what you're seeing here is 6 months and color-coded clinical microsystems that took care of Amy. Over that period of time, she was in 14 different clinical microsystems, 21 different visits, starting with a biopsy on the 27th of October. She received a MRI on the 31st of October, had a confirmation of a diagnosis of breast cancer, took part in shared decision-making, and was off and running in a plan of care and treatment. So 14 different microsystems, 21 visits over a 6-month period. Did that journey produce the best outcomes? How good was her experience? How much did it cost? So this is where value compass thinking comes in. If we go west, we have clinical outcomes, mortality, morbidity, symptoms, and symptoms in red because that's patient-generated information. We go north and it's functional outcomes, physical, mental, social, and overall well-being. That's PROMs, patient-reported outcome measures, point in time, repeated, shows us changes over time. If we go east, we get to experience of care, decision quality, coordination, my goals were attained. And once again, that's all in red because that's all based on PREMs and PCOMs, patient-centered, person-centered outcome measures. We go south to costs, and there's the direct healthcare expenditures that are captured in our data systems. But the indirect cost to the community of lost productivity is once again picked up by patient-generated health data. So that was meant to be a brief overview on patient-reported outcome measures, patient-reported experience measures, and PCOMs. And now we're going to take this overview and put it in the context of some, what I think of as classic cases running from 1998 to today, to 2023, on spine conditions, on arthritis, on metastatic solid tumors, breast cancer, and inflammatory bowel disease, where my colleague Alice Kennedy will step in. So in these cases, you'll see that PROMs are QI tools that can do many jobs for many different types of patients. Case 1, Dartmouth Spine Center. This is a pioneering learning health system. Jim Weinstein took a course that I taught on microsystems in the mid-90s, and he started a spine center program that was extraordinarily novel and used patient reported outcomes, as you will see, extensively. And Lisa Weiss designed the information environment to capture in real time patient-reported outcomes and to feed that back in many ways, to feed that forward and to feed it back in many ways that you'll see in the case. So if I showed up at the spine center, which I did, I'd have a need. I had a sprained back, as it were. I had an orientation to the spine center, and I was asked to complete a health assessment. And that health assessment fed into the initial workup or plan of care. And then I went into the acute care management track of the spine center. And on the left-hand side, it's people with healthcare needs. and some value compass basics. And on the right-hand side, it's the outcomes, the changes in disease status, functional status, satisfaction against need, and incremental costs. This is a feed-forward system. As you'll see, that an individual at every visit completes a health assessment. That health assessment is shared with the clinician or clinical team, and that puts them on the same page. All of what you're seeing here was generated by the health assessment. Takes people 20 minutes on average to complete. It provides a history and review of systems, risk factors, red flags, and then on the right-hand half, you'll see it's showing trends in outcomes, in pain, in functioning, and in disease status. Not only does this help the individual with the problem and the clinician devise and put in place the best plan of care and track the outcomes of that over time, it can be used to improve care and to improve science. So my colleague Jim Weinstein brought together 12 centers that provide spine care in the US. They started a 6-year study that was funded by NIH, the National Institutes of Health. It was a 6-year longitudinal study of people who opted for or were randomized to back surgery for 3 common conditions, or had non-surgical care for those 3 conditions. So a large number of patients were followed for 6 years, 12 different centers, over 100 different publications. So new science was being produced. And one of the things that they did in this study was to measure value. So this shows the results for herniated disc patients, outcomes at 2 years. If we go west, we're looking at disease status using the Oswestry Disability Index. Blue are people that had surgery. Yellow are people who did not have surgical care for their back problem. And what this shows is that the blue bar is longer than the yellow bar, that patients receiving surgery had less disability, clinical disease status. If we go north to functioning, physical function, using the SF-36, the blue bar surgical patients did better on improvement in physical functioning. Both had substantial improvements after 2 years, but surgery provided more. Perceived health benefit, how satisfied were patients with their improvement? Both groups are satisfied, but once again, you see that the blue bar, 78% versus 59% of surgical patients versus non-surgical patients were satisfied with how much the treatment had helped them. If we go south, we look at the total direct and indirect costs, and that was $27,000 per year for surgical patients versus $13,000 for non-surgical, direct and indirect costs. So surgery provided better results, but cost more. And on the upper right, you can see the cost in quality adjusted life years. Not only can this be used to measure value, to improve science, but also personalized or predictive medicine. So if you go to the spine center now, you enter your characteristics, and then you can see how people like you did if they had surgery or non-surgical care. So it provides personalized predictive medicine. In 1998, my friend and colleague, Stefan Lindbard, pictured here, came to visit Dartmouth. And the Spine Center had opened, and we were talking one morning, and I said, "You should spend the morning at the Spine Center, Dr. Lindblad." He did, and the next morning he was in my office. And he said, "Gene, we could do this in Sweden with our rheumatology quality registry." And they did. All across Sweden, adults with rheumatoid arthritis benefit from this system. So there is a patient registering data on swollen and tender joints pictured here. There's a patient module for symptom tracking and for self-management that provides them an overview of how they are doing. There's a clinician module that tracks over time clinical outcomes on the top green line against patient-reported outcomes on the next middle orange line against the treatments, the medications that were prescribed. So it gives us a longitudinal view of clinical and patient-reported outcomes against the treatments. And then there's a point-of-care dashboard. The columns are dates of visits. The rows are different measures, many of them patient-reported on the upper segment, clinical measures in the middle that are highlighted. And then on the bottom, we're looking at different medications prescribed. So this individual was doing okay. They were in the yellow zone on disease status, and they went to red zone. They went to a flare-up, exacerbation in November and December. And then you can see that by April, this individual was back better than before in the green zone. So very, very low disability. C-reactive protein showed disease in remission. What had happened was that the Remicade, the biologic, had worn off. And when that patient was switched to Oricombi, it made that difference, put that person back into a good state. As mentioned before, all across Sweden, care for RA patients is improving. This is 2005 to 2014. The proportion of people having exacerbations plummeted from 12% to 5%. Now it's at 4%. The red line shows all patients across Sweden. This covers over 95% of the population with rheumatoid arthritis. The blue line is a particular clinic, and that's the Gävle County Clinic for individuals with rheumatoid arthritis. And you can see that the blue line from 2005 to about 2009 was highly variable against the red line of all of Sweden patients. And then all of a sudden, in 2009, you see that the blue line is much more stable and is actually generally a little bit better than the rest of Sweden. What happened? Well, what happened was that the new director of the Gävle program said to the team, let's do what Dr. Lindblad has said. Let's actually use those patient-reported outcome measures as we see our patients. Let's encourage them to use those for self-management at home. Let's encourage people that are experiencing a flare-up to come in right away. And let's encourage people who are doing well to come in at least once a year. But if they're doing well, they don't need to come in. And you can see the results here. Case number 3, quite recent. This is Ethan Bash. Ethan is a cancer specialist. And in 2017, he reported a study done at Sloan Kettering for metastatic cancer patients, a randomized trial, 766 patients. The trial was very simple. All that was done, the random group that received the intervention reported their 12 symptoms related to breast cancer every 2 weeks by sending those results to a nurse that worked in the program. And if those results for symptoms showed an increase in symptoms, then the person was asked to come in immediately to receive a new evaluation. So this program ran for several years and indicated a randomized trial. And if symptoms were worsening, the patient was brought in And what were the results? The results indicated that at 6 months, health-related quality of life had improved, and that improvement persisted. 1 year quality adjusted survival was better in the PROMs group, as was long-term survival. So this has become a real classic, relatively new case showing that PROMs can actually, in this case, not only improve quality of life, but extend life. So this shows patients at 8 years of follow-up. The upper line in orange were in the symptom monitoring group. The green line below was the usual care group, not using PROMs for symptoms reporting. And you can see the difference in survival. This study was very important in spreading the word on the value of PROMs for different populations in our country. The fourth case is current. We're in 2023, and my colleague Alice Kennedy will provide you a summary of her case. Alice.
Thank you so much, Gene, and thank you everyone for the opportunity to be here. My name is Alice Kennedy, and I am a research project manager with Professor Nelson's lab and a part-time PhD student at Jönköping University in Sweden. As Gene said, our final case today will show using patient-reported outcomes to improve the quality of care for people with inflammatory bowel disease, or IBD. Next slide. So the IBD Chorus Learning Health System began in 2016, led by Doctors Corey Siegel and Gil Melmed, and it was 10 sites committed to decreasing variation in care and improving the quality of care for adults in the US who have inflammatory bowel disease. Today, that number of sites has grown to more than 40 sites who share this common goal. This learning collaborative collects patient-reported outcomes via a brief pre-visit survey and puts these PROMs to work in 2 different ways. The data is de-identified and fed forward to a registry, illustrated at the top here, for national population level research. As you see at the bottom, it is also fed back to the sites as performance reports to inform small-scale testing and quality improvement. So today we're going to focus on that second use, using these patient-reported outcomes as a tool for quality improvement. So as you have seen in Gene's other cases, these PROMs can also be used to populate a patient-facing dashboard for symptom management. For IBD Chorus, this is currently in a prototype, but it hasn't yet been operationalized in a way that patients and clinicians would like it to. So further development is planned in the near future. Next slide, please, Gene. So how do we do this? Here we have our data collection tool, the IBD Chorus pre-visit survey. As stated, this is brief, and although the questions change from time to time, great care is taken to never let it exceed 1 page so as not to be burdensome on the patient. Periodically, some of these questions will be changed to focus on outcomes related to the current focus of the Quality Improvement Initiative. For example, currently, this collaborative is focused on reducing urgent care need and optimizing treatment outcomes. So some of the key indicators that they're looking at ask questions like, do you believe you would benefit from a change in your treatment? Have you been to the emergency department in the last 3 months? Have you been hospitalized in the last 3 months? And how confident are you that you can control and manage your symptoms related to IBD? So that's how we collect the data. And here is how we use these PROMs as a QI tool, the IBD Chorus feedback reports. These reports use statistical process control methods to help the sites identify special cause signals of statistically significant variation. This chart shows patient-reported emergency department utilization from November 2020 to November 2022. In each chart, the green lines show the mean or average for the time period. The red lines indicate the control limits that show 3 standard deviations away from the mean. These can be used to assess for significant changes over time. These graphs allow the sites to benchmark their QI progress in a few different ways. In the top graph, Jean, can you animate in the first animation, just one click? In the top graph, you can look at your own progress over time. Are you doing better than you did last month? Can you do the next click, Jean? And we'll look at the middle graph, which shows the entire collaborative average over time there at 8%. And it allows you to ask the question, is the collaborative doing better than it did last month? Let's move down to the bottom graph. One more click, Jean. The bottom graph is a cross-sectional chart that shows individual site performance compared to other sites and the collaborative overall. For example, we can look at site 67 and see that their emergency department utilization is higher than the top red line, showing that it is statistically significantly higher than the collaborative average, that green line. And we'll also look at one that is statistically lower. One more click, Jean. Here at site 8, which is below the lower red line. We might want to know what we can learn from each of these sites. What challenges are they facing, as well as what is working well? So why do we use these PROMs? It's so we can answer the question, how will we know if our change is an improvement? Here we look back a little bit further in the collaborative history, and we see that their improvement work to decrease urgent care, including emergency department utilization from February 2018 to April 2019, that highlighted portion to the left. If you take a look at the red circled area to the right, you might see something interesting happening in May 2019. The emergency department utilization for the whole collaborative decreased sharply and stayed below the mean, or that green line, for more than 8 points, which indicates that there was actually a downward shift in this metric, which is a statistically significant reduction. On the next slide, we can look further to see if this improvement sustained over time. So let's take a look. Oh, here we are. Thank you, Jean. So taking a look here, we can see that the Urgent Care Improvement Initiative timeline continues on, and we cut the data where we started to see that sharp downward trend. In the bottom graph, we can look over the next 3 years and see that they have indeed sustained this decreased average emergency department utilization of 8%. Even though they have had some periods of significant variation, over time, they have in general maintained this 8% average, staying inside of the red lines. So we didn't have time today to deeply explore these statistical process control methods, but if you would like to learn more about it, I would love to recommend the textbook, Practical Measurement for Healthcare Improvement, with the reference on the bottom of this slide. And at this time, I'll send it back to Eugene.
Thank you, Alice. Great summary. These cases, these 4 cases, show that PROMs are QI tools that can do many jobs. As you saw, they can be used to improve self-management, to avoid exacerbations, to improve care experience by jump-starting the office visits. It can be used for shared decision-making, to provide predictive analytics, to create part of your patient registry that can be used for improvement and for research and for value measurement. So feeding forward the PROMs to do the right thing now for this patient, and feeding back to improve outcomes, experience, value, and science for future patients. Brief comments on getting started, basic practical steps. And I've noted in the questions that there's a good deal of interest in how PROMs might work in hospitals. And here's a listing of basic practical steps, starting with a co-design team that includes different members of the microsystem or microsystem teams by role, as well as patients and family members whenever possible. Looking together to create a vision of success. What would success look like for using PROMs with this kind of patient? Third is to create dummy data displays. So now imagine what the data would look like and how it would be displayed that would be most helpful. Step 4, measure selection. Identify brief validated measures that can be used to provide the PROM information on outcomes and experiences. Next, step 5 is actually to design a questionnaire or a health assessment that includes the questions that you've selected that would be used to create your data displays. 6, building the questionnaire and the data display to show the results from the questionnaire. 7 is we're into basic quality improvement. One patient, one provider pilot test using small tests of change and agile design methods to make the process of collecting and using the data smooth and to be actually helpful to the care team and to the patients. And then an implementation process so that the best method can be adapted, adopted, and spread throughout the setting. So the key point here is that PROMs, patient-reported outcome measures, patient-reported experience measures, perceived health benefit, are quality improvement tools that can be used to improve patient-centered outcomes, care experience, care value, and advance science, while also improving professional workflows, efficiency, and joy in work. Thank you for inviting me to give this presentation. We'd like to open this up for questions and discussion.
Thank you very much, Professor Nelson. You see, there are quite a few questions. For example, I think some of the questions have already been answered in your slide on how to getting started. That was a very important slide, which covers most of the questions raised by my friends. But one question is that do we have any standardized PROM tool which you might have developed, which can be used across?
Yes, there are literally scores of standardized PROMs tools that are being used globally. One that I mentioned is the SF-36, which gets at physical function, mental health, role function, health-related quality of life. It's probably the most widely used patient-reported outcome measure that can apply to any person when applied point in time and over time. And it's been with us since about 1986. More recently, NIH invested for 12 years in a system of measures commonly called PROMs. And the PROMIS family of measures are now translated into about 20 different languages. There is no cost for using them, and they are individual items as well as sets of items to get at different aspects of outcomes. And each item has been calibrated on a 0 to 100 scale. And it's possible to select items or to take standard short forms or long forms from the PROMIS family. They're also available using computer adaptive testing so that rather than asking 10 items, measure depression. It usually takes 2 or 3 items to measure level of depression. So there are in general, there are generic measures of patient-reported outcomes and condition-specific. There are many condition-specific measures that have been validated for different kinds of problems that people have. So generic, like PROMIS, like SF36 or SF12 or SF8, condition-specific, like the ISQua Street Disability Index for back pain is a very good example. So these measures are out there, not too hard to find using the search engines that we have today.
Okay, there are quite a few questions on, the detailed roadmap on how do we really implement in the hospitals in the Indian scenario. There are 3-4 questions. I want to tell the viewers today that, the CAHO has, some of our members in CAHO have been preparing on this subject, have been studying on this subject. And surely in near future, we'll be conducting the detailed workshop. And we will again take help of Professor Nelson. And so you have to wait. This session is basically to sensitize. But more importantly, I'm very happy that in just 45 minutes, the kind of case study which was presented has really given an insight out about the PROM and PREM. So that is one. But one specific question, I don't know whether that is relevant today to ask this, that how frequently we can take the feedback for surgical site infection surveillance. This is a very specific question, but I think this will come like that, where there will be many such questions, but somebody has asked this question. So do we answer today, Professor Nelson? Surgical site infection, how frequently the feedback should be taken?
Yes, well, I think the answer is to look at this from a, let's say, a pathophysiological point of view. And as we look at the population with surgical site infections and observe how frequent, how the speed at which the condition is changing. And if we understand, let's say, the variation in the population of people with surgical site infections and the speed with which that's changing, you'd be able to start to say, well, if we did this at an interval of every X hours or every X days, this would be correct. So I think, looking at the basic understanding of the course of the surgical site infection, the flaring and the healing, and its response to treatment, you'd be able to, by consensus amongst experts and clinicians, to come up with the right interval.
Okay, that's, I think you have answered it. And so Anuradha, you have any points to comment on our CAHO preparation? Anuradha?
Yeah, it is really good. Thank you, Dr. Eugene, for a very great presentation. And thanks again to Ms. Alice Kennedy also for this great presentation. Really good. I think our whole group has been sensitized to what is PROM and maybe we need to take it further in CAHO as a workshop, as Dr. Girdhar Gyani sir pointed out. Thank you so much.
You're very welcome. A comment on implementation in hospitals, with that special interest that you have. My sense is that to start in hospitals, that you would want to have, let's say, some clinical champions who are in the hospital that are very interested in using PROMs, a few respected clinical champions who have the time and the interest to be the pioneers in testing the system out. And then once you look in on a specific population, patients in this ward or in this unit with this condition or these conditions, I think the areas that would be most productive first to use PROMs, one is in symptom monitoring asking people that are able to report on their symptoms on a regular basis. And that's done now, of course, formally and informally, systematically and not systematically. And by using a PROMs approach, you might get a more systematic method for symptom monitoring established using both patient-generated information as well as clinician-generated information. So symptom monitoring would be first, understanding the patient's goals and concerns, agenda setting to try to understand as you develop the treatment plan, next steps, what are that person's goals and concerns? What are they worried about? What are they hoping will happen? And that is puts you on together on the same page to understand from a pathophysiologic point of view, I get this. From a patient point of view, they're saying this. Now let's put this together. And that leads to shared decision-making. There's little shared decision-making and there's bigger shared decision-making. So having that kind of conversation about symptoms, about goals and concerns, and then treatment options, shared decision-making is another potential target in the hospital.
Thank you.
Can I come in, Dr. Gyani?
Yeah, Dr. Vishnu, I wanted to come to you. Any quick comments?
Yeah, quick, because thank you, Professor Nelson and Alice for this, and Dr. Gyani for taking this forward. We have started doing our outcome measures and also the PROMs for the coronary artery disease. We capture the health status, the outcomes, and the 3 PROMs that are captured are the Seattle Angina score, Rose Dyspnea score, and the PHQ-2, which is gives the mental status. And for joint replacements, we are doing it with taking the Oxford knee score and the knee suicide score, which captures both functionality as well as the pain part of it.
Okay.
So these things are already available, and I think so. Going forward, as healthcare providers across the country, we have to start doing this because the patients have to see the value. Otherwise, because there's a lot of trust deficit against healthcare, and the customer, I'm talking to the patient now, they are much more demanding, and we have a sort of obligation to see that we provide the best. So I think so. This is a long way to take it forward, but I think so. We have to make a beginning, and CAHO is the right forum to sort of lead it forward.
Thank
Well,
you.
thank you for
And
those-
I come now to Dr. Vijay Agarwal for the closing remarks.
No, thank you, sir. It has been a brilliant session. Absolutely. And I think we will need champions like Dr. Vishnu, who have already started. So he needs to share his journey, his experience, the beginning one. And we have to cross the boundaries, sir. We have to break it, that it has nothing to do that it will happen only in Fortis Healthcare. You have to now, lend your hand and see as to how can we make many more clinicians and hospitals to start following it. And this has to become a movement, like what Dr. Gyani said. How do we make implementation of PROM? And as I was talking to him, this is the agenda for CAHO in 2023, to make PROM a reality in India. Sir, this is please do accept our certificate of appreciation to Professor Eugene for conducting this webinar today.
Thank you. It was an honor and privilege to be with
and
you.
Also to Ms. Alice Kennedy. Really grateful to both of you for this wonderful webinar.
Thank you so much.
Thank you very much. And thank you, Dr. Gyani, for conducting this beautiful session.